All right, welcome back, everybody. As I'm introducing everybody, I have forgotten to introduce myself. So I'm Madhu Teixeira, Board President of the NIHHC. And again, thank you all for being here. Now I'd like to introduce you to Dr. Rebecca Johnson. Dr. Johnson is a freelance public health researcher specializing in partnership and facilitation across the states of Illinois and Indiana. Some of her work includes training on research tools such as surveys, interviews, focus groups, photo voice, mapping, evaluation, and dissemination. Among her accomplishments include evaluating older adult priorities for CJE Senior Life and co-designing a bilingual training program for home care aides at Help and Home.
Hello, everybody. Yes, I'm Rebecca, and I'm based in Chicago. So I just want to say thank you to everybody for welcoming me here today. I'll just test can everyone hear me? Is that good? Okay. All right. Okay. So my role in the next 30 minutes is to guide you through the quantitative part of the study. We've produced a report, which is a very in-depth report on the qualitative and quantitative work we did, I'm going to start the ball rolling on the reporting with the quantitative section. I came late to the project. I met Liliana, the PI Liliana, on another project here in Indiana, at the Department of Health, and she came to me. I think it was last year, to ask me to help analyse the data collected by a survey for this project. So before we go any further, I do want to extend a really heartwarming thank you to Liliana, to the PI of this project, Liliana Quintero, and the research team, because I've been absolutely bowled over by the professionalism and the dedication that made this study possible. I couldn't have done the analysis without all the hard work that had gone into the outreach, the partnership, all of the design, all of these things that come before you get to the data, all the things that have to go in, the teamwork that goes in before you get to the data to be analysed. And also, so I'd like very much. I think we'd like to. Liliana and I decided we'd like to appreciate everybody by asking the team to stand up. So that would be Liliana, Jean-Marie, Zuleya, Kamud, Sheng, Iraida, and Dylan. So these are the wonderful people. And there are copies. There are copies of the report outside, hot off the press. I have to say, we've been making sure it's all accurate and checking it all. So, but I would I'd really encourage you to. This is a summary of everything that we will be talking about in the next sort of next two presentations. Yes, so without this wonderful team, we wouldn't be able to sort of talk to you about these results. Okay, thank you. All right, so as you've heard from Dr. Weaver, there's a lot of data out there, and Dr. Weaver gave a fantastic contextual summary of the big data that is out there about this topic, infant mortality, and the purpose of it, which is to lead to infant vitality. And I think traditionally, research around public health issues like infant mortality are led by providers or university health research hubs. It typically happens from the outside, really, in many ways. But this messaging, I think, can sometimes feel a little like one size fits all. I mean, I actually really appreciated the way that Dr. Weaver was showing you the differences between, she was showing you the priorities which were coming out, but she was also highlighting some of the differences which are evident in the big data, but it's still big data. And one of the problems can be that the messaging can sometimes feel like a one-size-fits-all approach. But as we know, that's not the case. One diaper is not going to work for everybody. So yes, and so it can feel a little bit like that. And you can feel like that, I think, when you hear some of the headlines. So 2024, as Dr. Weaver said, this data has been kept for year on, year out, and in Indiana since 1900. So there's a real track record of what the issues are and what's emerging. And recently, there's been a lot of headlines, say things like a troubling spike in sleep-related deaths, for example. But you may be thinking, well, does that affect me? Does that affect my area? Is that really affecting the people I know? And that's a big message. So, as I say, messaging can sometimes feel like a one-size-fits-all approach. And it's important to raise awareness at that general level, but it's also important to understand, as Dr. Weaver was saying, what's happening at a more local level. And we did realise, I say we, the team, the research team, we did realise that sometimes the information, the big data from which is representing the Spanish-speaking population, it doesn't necessarily go to a very local level, and it can actually be that can be a little bit hidden. The local can be a bit hidden in the big data. So, for example, the Beacon Hill assessment, which is a fantastic community assessment, for example, I must say. So I want to say it's a very, very good one. I think we were looking at our data in the context of these other health assessments. But out of a number of surveys of 1,473, 289 came from Elkhart, and of which there were 85 people said that they were Hispanic or Latino. So that's actually very small when you think about it. And so NIHAC hypothesized that by using a mixed method approach, which is what a qualitative and quantitative methods refers to, a mixed method approach, with the staff surveying and interviewing members of the community about infant mortality and related factors, we could reach more people within a particular area, and we might be able to capture data to reassure people that the conceptual models of perinatal health and infant mortality are actually reflecting the community priorities in Elkhart. And so that's our aim one, was to develop, I think, or in a sense progress the conceptual model which Dr. Weaver beautifully laid out for you. But it's to develop it so that those terms which have been tracked over the years are relevant for people. They're also relevant trying to show how relevant they are to us here in Elkhart. We also hypothesised that by exploring the subjective and lived experience of people, we would be able to and explore community perceptions of infant mortality. We would be able to get a better sense of how the big data, is being lived in practice on the ground, and get a better match with interventions which are needed here. Okay. Oops, that's it. So what did this mean in practice? So what this meant in practice was a huge amount of work, which went right the way back to enrolment. It meant back to training NIHHC staff, trained bilingual community health workers and outreach staff, to collect two paper surveys. One was a demographic survey and one was a survey with questions about infant mortality, to collect these at events at 30 locations. And people completed the surveys in their preferred language. Majority were completed in Spanish. And as you can see, we didn't just collect surveys. At the same time, Dr. Place and Liliana were having conversations in focus groups with providers and also birthers, similar questions, but giving people the time to reflect on their answers in a more sort of relaxed environment. So we were very, very pleased that we managed to collect surveys, remember 2 surveys, from 511 participants, the majority of whom were female, and there was a nice number there under 18. I think one of the things that struck me from Dr. Weaver's one of the things that struck me from Dr. Weaver's presentation was that the age range of people who were are impacted by infant mortality. And so we're very pleased that we could get this 6% of under 18s, people who are going to be thinking about starting a family and family planning. And 69% of people were employed. Okay, here we are back. Good. So the from infant mortality to infant vitality study, our study is unique because, as I said, it's a by the community for the community study from start to finish, and it is a cross-section, what's known as a cross-sectional study, which is collecting data from a sample population at particular points in time. So the particular points in time are the health events at the 30 locations. It's like taking a snapshot. And these studies are useful for describing characteristics of a population, identifying priorities, but they do have weaknesses, and I do want to acknowledge that they do have limitations. And one of the things, I think, as one of the focus groups respondents put it quite well, I don't necessarily want the questionnaire with 1,000 questions, and that is the problem with these type of methods. And so that is why I think it was so important to us that we also followed up in focus groups. People get tired of asking questions. I know, answering questions, I know they do. Yeah. Okay. And the value of the approach, as you will see, is that the community team can discuss, they can see how the data compares with the population level data being collected to make recommendations make sure that recommendations at a local level actually match up with state and national levels, and have discussions about how the statistics interact. Okay. So today, on behalf of the team, I'm going to present the priorities which emerged from the main survey analysis. And as you can imagine, 511 people produced a lot of data. That was 14 questions on the infant mortality survey, 9 questions on the demographic survey, a lot of data. And this table shows that the questions we asked, that's under the core measures, the study themes that we're reporting out under, which are basically local awareness, knowledge and attitudes towards perinatal health, the barriers to accessing services, and some of the needs and gaps that emerged. Right. Okay, so let's start then with what we learnt about the community from the demographic questions we asked. The first thing to say is that the majority of people, as I mentioned, just a bit of context, the majority of people said self-identified Hispanic. 83% had a Spanish language preference, preferred language of communication. Now, why does this matter? I want you to remember that as we go through the data and go through the priorities, because the language we choose to speak and prefer to receive communications in, I think, emerge as a more reliable measure than race and ethnicity when interpreting community needs and priorities. And I think you'll see why I have that thought in my mind as I present the data. But so that's just something to bear in mind. But here are two demographic areas, age and gender, which were also very significant. And this is a population pyramid. For those of you not familiar with the population pyramid, it shows you the distribution of the survey in a population by age and gender. And this actually shows a rather nice, from a statistical point of view, it shows you a nice normal distribution where you've got sort of almost small number of 18-year-olds, and you've got sort of a bigger group, 25 to 45, and then you've got the older group at the end. So looking at this, you've got a wonderful distribution, very sort of what's considered a normal distribution for age and gender represented by the survey. And why does that matter? Why is age and gender interesting? Well, I think the number of respondents aged 24 and younger, that's 26%, suggests that infant mortality is and will continue to be an issue for the whole community, because the 18-year-old is going to move into the family role, and so it's going to be an issue for a few years forward. So it supports the argument for community-wide communication campaign for everybody. Now, finally, the other demographic, which was very important and proved significant when we were running the data, was place, or as we asked for it, geographic location. And this is just a very brief summary of the geographic locations which were most frequently put onto the demographic form, at the events where NIH surveyed people. And the blue circles represent the top 5 zip codes which were listed by people who attended the high school health events and outreach, and the red ones represent the flu shot events. Now, you'll know much better than I do how these locations relate to service provision and access to things like healthy food. But what's valuable about a map like this is that you can see where NIHHC is positioned to help you reach people, and the range and the scope of the location. So to conclude the demographics, the snapshot of community characteristics from the demographic survey, the principal variables, the things to hold on to when we were looking at the answers to the survey, the infant mortality survey, were that age, gender, language preference was statistically significant. And I think one thing to take away for people who deal with data, statistical analysis in the room, is that the other questions, highest education level, place of work, country of birth, were the ones we didn't collect. We didn't collect enough data to determine whether they were significant or not. It was age, gender, and language preference that were the most useful for our analysis going forwards. Okay, so moving into the infant mortality survey results, as I showed you a table where we'd grouped the analysis under 3 headings: awareness, knowledge, and attitudes, finding out what the barriers to accessing services were, and some of the needs and the gaps. Now, assessing levels of awareness is important, certainly to researchers and policymakers, and as well as providers, because understanding how much people know helps us to focus on, what communication campaigns to do. But the term infant mortality may be meaningful to policymakers and researchers, but what does it mean to the members of the community? So to find out, we asked people, if someone told you that the highest rate of infant mortality amongst Hispanics in Indiana is in Elkhart County, would you believe it? And you can see the analysis of the comments in the survey was a resounding no. What was interesting was when we did the statistical analysis of this, it was stronger amongst women. More women were saying no as well. So more women than men did not believe this. So it did raise the question at this point, when we were looking at this data, whether or not the community wanted to talk about this topic. So that was something we had to bear in mind. Another question that we asked was, what does the term infant mortality mean to you? And here's where place becomes very important, because on average, on average, only 32% of respondents in all zip codes selected the death of an infant before 1, which is the term, the definition of the term we're using. And perhaps more importantly, more respondents selected the death of an infant before 1 in zip code 46526 than in 46514, 16, or 17, which, as Dr. Weaver showed you, is where the biggest sort of areas of concern for infant mortality here in Elkhart. So place is important as well. Very important here. And perhaps the significance of this is that we need to when I say policymakers, researchers, it suggests that terminology can be a barrier itself, and it's very important to help explain what we're talking about and constantly explain what we're talking about and how we're defining terms. Just as a coder, one interesting thing is that 65% of respondents under 18 selected the correct definition of infant mortality, so suggesting that the younger members of the community, who, as we see, are going to be becoming more aware of the issue as time goes on, are a little bit more prepared or with the American definition of infant mortality, and the global, not just American, global definition of infant mortality being the death of an infant before one. So data like this, particularly the place data, is very useful because it helps to decide where to focus outreach efforts and where they might have most chance of misunderstanding and confusion, where there might need to be an extra effort. I think going back, it also perhaps this quote I really took away with me, and it's sort of sat with me. It's not a relationship with your race. And so I think, again, going forward, I think that more important than race and ethnicity is place and language preference in terms of thinking about communications and messaging. Another benchmark we asked the community is about the causes of infant mortality. As Dr. Weaver showed you, there's a list of causes that are nationally recognised, nationally acknowledged, nationally tracked. And so we wanted to get a sense again of how aware people were of these causes how aware people in Elkhart were of these causes. And as you can see, again, it's limited by the choices provided, but as you can see, a number of respondents here selected I don't know. So there's a very high number of I don't knows here, which means that we have to take that into account. But despite that, the community members were also prioritising health complications, premature birth, and sleep practices. So these results, on a whole, show a suspicion of big data, I think, uncertainty about terms and causes, leaving the question a little bit, okay, well, we're going to have to work hard in terms of how we message, and definitely the flagging that there needs to be a lot more engagement about how to communicate about this sensitive topic and to be very aware of place when we're doing that. Finally, one other thing that we did in the survey is in terms of assessing awareness, knowledge and attitudes, was asking, do you know what emergency Medicaid is, and do you know what the WIC is? And interestingly here, you'll see that a high number of people didn't know. The high incidence of low knowledge or awareness of emergency medicine and the WIC is particularly noteworthy, I think, in the light of two things. First of all, there is actually some data, general data, published by the Centre on Budget and Policy Priorities in 2022 that only 60% of eligible people in Indiana are using the services that they're eligible for. And secondly, I think later on, as we'll see in a rating for another question, nutrition is a concern, is a big concern. And so raising awareness of emergency Medicaid, WIC, is actually something that could help to bridge this particular barrier or need. So that was awareness, knowledge, and attitudes as a whistle-stop tour to some of the findings from the survey about that. So moving on to barriers to accessing services. So we asked, as Dr. Weaver's presentation illustrated, low access to prenatal care, inconsistent quality of care during pre- and postpartum care for mothers and babies. These can all be shown to directly impact infant mortality. In addition, other factors, socioeconomic status, access to affordable housing and healthcare, also have impacts. This is what the research and the big data is showing. So this is why we ask people this range of questions. We ask them, when I think about taking care of a baby or keeping them safe, my main concerns are. And we're asking them about whether they have support from family or friends, which is a social driver. I'm new in this country, I can't afford doctor's visits. So these are why we're asking this range of questions. And I think, and what comes out very clearly, sorry, is that? Yeah, what comes out very clearly is that not having health insurance or Medicaid was number one priority for people, that when they were thinking about keeping a baby safe and it's the number one factor that communities deem necessary for a successful pregnancy. And in addition, I think what's of interest takeaways, survey respondents also selected financial stability and safe, stable housing as other core factors. And I think this is particularly noteworthy given that the majority of these respondents were employed. So that's definitely something to keep in mind. We also asked a question, because asking about concerns, I think, certainly my experience of working with community organisations is that it's a very it's a negative way of doing it. It's not encouraging. It's our problem we have with infant mortality versus infant vitality. How we ask the questions matter. So we also asked a similar question, but this time in a more positive way. For a successful pregnancy and healthy baby, my life would be easier with. So similar list of social drivers, similar choices. But Medicaid, health insurance Medicaid was again number one, even when we're asking again the same way. The statistical analysis, I used Pearson, chi-square and Fisher test, showed significance. This was more significant for women, again. Women, which means women were more likely than men to choose that they need the health insurance, better understanding of the health system, and also women were more likely to choose than men to choose healthy baby. It would be easier if fluent in English. So I think of note, so we've got two questions there asking similar things, giving similar items for prioritization, but we're noticing that there are sort of similar priorities coming out. And so the descriptive and statistical data is showing some variation by gender, as I said, with more women than men selecting better understanding of the healthcare system as a need. And it's also highlighting the role that language proficiency can play. And Dr. Place will talk more about the focus group data and the lived experience and the information that provides additionally to these prioritizations. But one thing we did want to say is, we want to show you, is that we did actually put the two together, put the results and the two questions together. We had barriers and we had needs overlaid. And the team this helped us have a very good discussion about the reasons for the ratings in these questions. And not just the reasons for the high ratings, but perhaps why some of the lower ratings were coming up. So we also combined some of the items. And so when we combined costs and jobs and when we combined costs of having a baby and having a job, financial stability was clearly the top concern and need, followed by health insurance. So that worry and that concern about the finances needed during having a baby was something that came out very strongly. But give an example of a low, what comes out statistically as a low barrier, which is transportation here. You can see number 2 seems quite low statistically, and yet, as Dr. Weaver her slides were showing, transportation it can be a big issue. So we had a good discussion about why this was coming up low in this survey, and because something like no transportation has a significant impact on well-being. But what the team were thinking is that often immigrants arrive prepared to overcome something like no transportation, because they're prepared to work with their support of their informal networks and their social support. What is less expected is a lack of access to essential public health needs, such as health insurance or a job. Those are sort of what the British would call a sort of a googly, as it were. It is unexpected, very unexpected sort of thing, and it demands a quick something that's difficult to plan for. So. So I wanted to draw attention to sometimes what appears as a low priority in a survey. It shouldn't just be dismissed. It needs perhaps a little bit more of a further discussion with the team. Again, the value of doing surveys like this within a community organisation enables us to have the conversations as to why these things are appearing as they are. Okay, so those were some of the barriers to accessing services, and then moving through to the third summary, the needs and the gaps that came out of the survey. So we asked the question: for a healthy pregnancy and baby, we need to think about. So what do we need to think about? So we can see that this aligns with what Dr. Weaver was presenting. We can see that prenatal care, regular checkups, was selected as a number one need, number one factor impacting a healthy pregnancy by survey respondents. The second most important one is nutrition. And then after that, we had not smoking and not drinking. Now, this again is where place can be very helpful in terms of targeting messaging. Because when we analysed by groupings, when I mean groupings, I'm thinking where the surveys were collected. So whether they were collected at health fairs, whether they were collected at flu shot clinics, whether they were collected at outreach, it does actually show some variation between those groupings. For example, the flu shots, prenatal was number one, but not smoking and not drinking was number two. And again, this is an example of how valuable it is to talk about the statistics with the team, because the team shared that many factory workers smoke, so they weren't surprised to see not smoking coming up higher than amongst that group. Again, these differences, I think, the statistics from the survey can do is they can help us to really think about the added value of matching messaging to audiences in different places. Another need and a current gap identified by the survey was for what sort of information and services were needed. And so our priorities here were shown that people were prioritising sex education and preconception health. Now, this is actually very interesting because it would suggest the community would welcome more engagement and education around family planning. And the finding that sex education and preconception was a priority need is something which you'll hear is reinforced by focus group participants. And in this case, Dr. Place's focus group data will give us a better sense of which age ranges were requesting that, and also people's appreciation for the education which is already taking place in the community around that. But you'll get a better sense from the focus group as who was requesting these information and services. So, in conclusion, this is to conclude the quantitative portion of today's event. There are 5 priorities which the survey data draws our attention to. And this, what I mean, is their priorities in terms of how many times they were selected by the people who completed the surveys. Number 1, prenatal care. And if you think of it, 511 people took the survey, 407 said they wanted prenatal care. Nutrition is very high as well, up there. And as I said, some little deviation between not smoking, not drinking, but place can help us sort of target those messages. The lack of health insurance, Medicaid, is a big one. Again, 355 out of 511 is high. We've got this twice because we asked it differently, so we put it up twice, and then we've got stable housing. If I were to revise the slide, I would say that what we've got here is I would have financial. When I'm combining the components, financial stability is also very important, and access to healthcare services would be up there. But this is a good starting point for the priorities flagged by the results. The other thing that we did is, so we mentioned at the beginning, okay, where is this all going? So one of the points of collecting results like this, research like this, is to get a sense of priorities to communicate about or priorities to educate about. So we also wanted to know what communication channels were appealing to the Hispanic community. I don't think you'll be surprised to hear, or surprised to see, that number 1 priority was Facebook, number 2 was in-person events, and number 3 was WhatsApp. And this type of insight is, again, very valuable because, first of all, there was no significant difference in preference groups surveyed by age or gender. So there's no significant difference between how old people were or whether they were male or female. And I think the communications selected here, Facebook, WhatsApp, in person, they're not passive interactions as something like television can be. You can communicate, whereas you can't really, unless you're shouting at the television, you can't necessarily communicate with the television. It won't answer you back. So things like Facebook, WhatsApp, in-person events, these are all opportunities to have further conversation, ask further questions. And so the key takeaway for me, I think, as well, is that perhaps a mixed messaging, culturally relevant approach in the language preferred is actually very, very important. Okay, so here I conclude the survey, the presentation of the survey findings portion of today. And before I hand over to my good colleague later, I think after a wee break, Dr. Place, I just want to end by saying that although these priorities are very helpful signposts for strategic planners and providers, still a lot of questions around them. For example, is the confusion about the term infant mortality an insurmountable barrier to prevention campaigning? Is it going to turn people off? Are the social drivers rated low, less important in reality? As we've seen, having conversation within a team made us, think hard about transportation and why it was being rated that way and why the big data was saying it was much more important. And most importantly, what's missing here is what do providers have to say? Do they prioritise the same things? Regular checkups during a pregnancy, are these a priority for providers? And are they a priority for pregnant women as well? Do birthers think sex education and preconception help should be priorities? And so without further, if we don't explore the lived experience, we risk building a bridge which doesn't quite meet in the middle. And this is why it can feel right, it can feel the right answers, but it's those little tweaks where we have to get the measurements and the figures so that the bridge is fit for purpose for everybody. And this is why the team conducted focus groups with birthers and providers as well. And that's what Dr. Place will talk you through. She'll talk you through the lived experience, which is sort of basically converging and diverging from the survey priorities which I've just presented to you. So thank you very much for listening.
Thank you so much, Dr. Johnson. Thank you for diving. Last night we were having something to eat, and at the restaurant the lady said, "What are you going to be doing at the aquatic center?" The waiters, and we say, "We're going to be diving in numbers, diving in big numbers." So we appreciate your attention, but I think that the only way to make informed decisions is presenting this kind of research that are coming from our community. That is one of the big lags and harder to get it. So I think that we have a couple minutes for questions. If anybody has a question for Dr. Johnson before our break.
I am Kimberly with Beacon Health System. Thank you for the call out there. I do appreciate the acknowledgement that going deeper and specifically engaging with community is important. So I thank you for your research. The question that I have is, you've mentioned that the key themes were awareness, knowledge, and attitudes. Did trust come up at all? When
Yes.
engaging with the
Yes.
community around engaging with either clinical or non-clinical providers?
Yes, that's a great question, and I think Dr. Place will cover that a little bit more because it was definitely the focus groups where I think people felt more comfortable and able to share that. And I have a funny relationship with surveys because they're very valuable, but they don't actually enable people to talk while they're answering the questions. You're not getting that sense of how people feel about the question they're being asked unless you leave an open comment. So Dr. Place has a much more nuanced reality. What I do want to say, though, is that the quality of the outreach that NIHHC did was very much, as you know, that there are three golden rules to doing good research, particularly in communities, community engagement. There's making sure that people are informed before they do the surveys. There's the respect for the data, and then of course there's the issue of whether people trust the people who are giving the surveys to them. So in that sense, trust was it came before the analysis. But that's in a way that's why I couldn't have 511 surveys is an amazing number of surveys, and the data generated was very, very rich. We could talk about we could have talked about the data results for a long further, couldn't we? A lot of time. There's so much to say about that. But I think the trust from the survey perspective, the trust is embedded in that process.
And I think that let's take a quick break. I know that we have a lot of numbers to digest, so let's come back at 10:50 for our qualitative results presentation. Thank you so much. Don't forget to complete your survey behind your name tag.